will include challenges in the techniques, membrane versus centrifugation, to selective and non-selective plasma exchange toward the target molecules and its kinetics, in doses and frequencies, and in the diagnosis and ASFA guidelines. Unlike hemodialysis, plasma exchange and other blood purifications, including very critical approaches for the patients who are in need to remove specific molecules. We have many challenges in plasma exchange, including what we should remove specifically and the replacement fluid, what is the pathophysiological rule of removal and replacement in critical illness. The timing, what is the exact timing and the optimal to do plasma exchange in respect to other critical treatments. The doses and the frequencies and the regimen, what is the optimal dose and the regimen of plasma exchange. We have to weigh the risk versus benefits and how to identify critically ill patients at risk and to avoid complications, and more explorative indications. What are explorative indications for critically ill patients? Specifically, when patients need a tandem therapy of blood purification, like plasma exchange, hemodialysis, or CRRT. Before doing plasma exchange, you need to have a diagnostic workup before starting the sessions. A full biochemistry, blood count, platelets, coagulation profile, and importantly, a disease-specific test like Anti-GBM antibodies or other specific molecules need to be removed. The mechanism and removal should be identified, and the prescriptions of therapeutic plasma exchange, like membrane or centrifugation. We have to define the total plasma volume calculation and the number of sessions, the interval between each session, the anticoagulation, and the type of replacement fluid, like plasma or albumin. The apheresis versus hemodialysis. In general, a substance with a low volume of distribution, mainly intravascular compartment, and or high protein binding are more likely to be removed by therapeutic plasma exchange. With a substance that exhibit a low volume of distribution correlating to a higher plasma concentration are more susceptible to remove by therapeutic plasma exchange. This in contrast with hemodialysis, where substances are not tightly bound to plasma protein and that readily diffusible through the semi-permeable membrane are removed. In addition, instead substances free fraction results in decreased clearance with therapeutic plasma exchange as opposed completely to hemodialysis. The challenges in different techniques, including membrane versus centrifugation. The differences in techniques between centrifugation forces during centrifugation, therapeutic plasma exchange, and membrane filtration, and against hemodialysis. The mechanism differences in centrifugation using the centrifugation force, while membrane and hemodialysis are using convection, with hemodialysis diffusion process is the mainly way. The centrifugation needing lower blood flow, you can use a peripheral blood axis, while membrane filtration and hemodialysis need higher blood flow and a central venous axis, or arteriovenous fistula. The blood volume inside the circles are nearly equivalent to each other. The plasma extraction are high for centrifugation by centrifugation force, while filtration fractions in membrane filtration is really around 30% only. So the timing needing to complete the session by membrane filtration is higher than the time needing to do the same session for the same effect by centrifugation. The protein binding demonstrating that for therapeutic plasma exchange, the highest the protein bind substance or large molecules are ready to be removed, while on dialysis it should be low protein binding. The centrifugation using citrate, while the membrane filtration are using heparin. Both the plasma filtration using filtration technique and centrifugation technique are with the same effect. However, centrifugation are more rapidly removing and separating the plasma than the filtration technique. So the centrifugation technique needing more faster separation and need a peripheral access, while the filtration technique needs a central line, higher blood flow, and a slower plasma separation technique. There is no superiority between membrane and centrifugation technique considering the efficacy for removal of a significant amount of a specific molecules, with a non-significant differences when comparing the efficacy of membrane separation for therapeutic plasma exchange against centrifugation techniques. The immunoglobulin IgG and IgM levels before and after showing similar removal with both techniques. Challenges in selective and non-selective plasma exchange. In non-selective therapeutic plasma exchange, which is the commonest way we are doing for patients, are targeting for plasma removal or exchanging with replacement of fresh frozen plasma or albumin. However, if we need a plasma purification selectively, we need a double filtration technique, may using immune adsorption technique or a cascade filtration using double filtration or a specific adsorber like in lipoprotein apheresis. Cytopheresis are doing only centrifugations machine because removal of a specific cells, including erythrocytes, like red cell exchange in sickle cell anemia and thrombocytopheresis, leukopheresis for white blood cells or blood stem cells, and this is less conventional apheresis modalities require additional equipments, maybe photopheresis or others. Prescription of plasma exchange are mainly defined by which target molecules and its kinetics in circulation and its half-life. As a general principle, one plasma volume exchange removes a fixed proportion of around 60 to 70% of the target, while equilibration across the body fluid compartments determines the net clearance of such substances. The decision of the frequency determined by the intra and extravascular distribution and the rebound effect percent. General principle, 1.5 exchange of plasma volume is required. More plasma volume exchange is of no significant value and more costly. A big differences between immunoglobulin in its concentration and the percentage of the intravascular compartment. For example, IgM is the largest immunoglobulin and percent of intravascular compartment is the highest one. In the contrary of the immunoglobulin, IgG is the smallest immunoglobulin and its percent in the intravascular compartment is only 45%, meaning that a rebound area will happen. 6 points determine the rebound effect between molecules removed by plasma exchange. The challenges of kinetics including the following. The membrane sieving coefficient. What type of molecules could be removed? The substance plasma half-life. Substance with a shorter half-life may be sensitized more rapidly. Faster rebound will need for more frequent plasma exchange. extravascular concentration, what's called the volume of distribution, and finally, the disease activity and additional immunosuppression use will determine the rate of synthesis. Most diseases in nephrology, immunoglobulin IgG needs to be removed, so the kinetics of that is several consecutive treatments, each separated by 1 or 2 days, will be required to achieve a meaningful clearance. The intra-treatment increase is a result of equilibration between the intra and the extravascular compartment, as well as new immunoglobulin synthesis. Diseases with high autoantibody production like anti-GBM disease require daily sessions with concomitant immunosuppression. Challenges in drug removal with plasma exchange. The important factor for drug removal is kinetic. Drug prone to get filtered by plasmapheresis, including highly protein bound and a small volume of distribution, meaning its intravascular compartment is high. Drugs which are removed, including rituximab, around 50% removed, and other like eculizumab, immunoglobulin IG, mycophenolate, aspirin, while drugs which are not removed, including prednisolone, 1% removal, cyclosporin and tacrolimus are intracellular, cyclophosphamide and azathioprine. In double filtration technique, like in Apheresis and others, a filtration with plasma filter or membrane as its first step, then plasma drained to the second plasma separator, specifically targeting a specific molecule. Then finally, it goes to the waste from the second filter, and the fourth step is to replenish and replacement fluid to the patient. The example of double filtration technique including Apheresis, which had been investigated for patients with calcific uremic arteriopathy as a Apheresis technique. In this study, Apheresis was a promising treatment that potentially avoids major amputations and their consequences. Apheresis effectively reduces the determinant of blood viscosity and may have anti-inflammatory effect over both the short and long-term effect. Another example of selective apheresis including lipopheresis. Lipopheresis may be by using a specific device for adsorption or using a double filtration technique. Lipopheresis may offer also more benefits than lowering only of lipid levels by pleiotropic effect of plasma separation and removal of the many of the cytokines and inflammatory mediators. Patients with the maximum doses of anti-hyperlipidemic drugs have lipid levels undergoing cyclic rebound between apheresis process. The rebound may be within 1 to 2 weeks, meaning patient will live for apheresis procedure for lipids for life. Sometimes those patients requiring arteriovenous fistula. Challenges in diagnosis and in management according to the guidelines. Many challenges in decision-making of plasma exchange. One of them is the pregnancy-associated thrombotic microangiopathy, with the probability of diagnosis of TTP, HELP, or complete mediated TMA and catastrophic antiphospholipid syndrome. The ANCA-associated vasculitis, plasma exchange, and glucocorticoids in the Apheresis study showed that those patients, the using of plasma exchange did not reduce the incidence of death or end-stage kidney disease. So in the Apheresis studies, which is a multi-center randomized controlled study, death from any cause or end-stage kidney disease between plasma exchange patients group or no plasma exchange has no significant differences. and between standard dose steroid or reduced dose steroids. So there is no significant difference in serious adverse events. Serious infection at 1 year less common with the reduced dose of glucocorticoids. Following the results of this study, the role of plasma exchange in ANCA-associated vasculitis presenting with severe kidney failure with or without need for dialysis is equivocal, and KDIGO guidelines does not recommend its routine use unless they are associated with anti-GBM antibodies. One of the very important urgent need for therapeutic plasma exchange is the anti-GBM disease. It's a category 1 for both diffuse alveolar hemorrhage or dialysis independence, while if the patient becomes dialysis dependent with no diffuse alveolar hemorrhage, it's category 3. Anti-GBM may be associated also with ANCA-associated vasculitis. Those patients presenting with both anti-GBM and ANCA antibodies, and this double positivity, while the initial presentation is similar to the classic anti-GBM disease, the clinical course can be more severe and is more likely to relapse. The challenges in anti-GBM disease is the early diagnosis and should be within the first few days presenting by the patient, as the treatment of anti-GBM should start without any delay if the diagnosis is suspected, even before the diagnosis is confirmed by the anti-GBM level. In a recent trial comparing immune absorption and plasma exchange for patients with ANCA or anti-GBM removal kinetics, it's concluded that immune absorption and plasma were comparable in the removal kinetics despite faster reduction of the total immunoglobulin IgG with immune absorption technique, with no further benefits of immune absorption over plasma exchange in the removal kinetics of MPO, anti-PR3, or anti-GBM antibodies. And to remember that plasma exchange should be continued until anti-GBM level titer is undetectable. The great challenges in plasma exchange, including the thrombotic microangiopathy syndrome, which is a common ground and distinct frontiers. TMA have in a common a terminal phenotype of microangiopathic hemolytic anemia with end-organ dysfunction. However, plasma exchange in different causes of TMA is a challenging decision for initiation. So in the guideline for plasma exchange during TMA differ between the different causes. Only grade 1 category is for TTP or for TMA associated with complement factor H autoantibodies. A great challenge in patients with lupus nephritis presented by thrombotic microangiopathy and should be managed according to the underlying etiology of TMA, with the most common causes are TTP, antiphospholipid syndrome, and complement-mediated thrombotic microangiopathy. However, patients with lupus can also develop TMA due to chigatoxin, hemolytic uremic syndrome, infection, drugs, or malignancies. So according to the KDIGO guidelines, including that patient with lupus and manifested and start the plasma exchange and steroid while awaiting for the results and considering plasmic score for TTP. And if it's high, we should look for the low ADAM T13 activity and the plasma exchange plus glucocorticoid or rituximab are initiating. However, if it's a normal ADAM T13 activity, antiphospholipid syndrome nephropathy may be a diagnosis. So anticoagulation plus or minus plasma exchange should be considered. Lastly, plasma exchange in antibody-mediated rejection. Both DSA and non-HLA antibodies can be removed with plasma exchange, double filtration, immune adsorption. Apheresis is always performed in conjunction with other immunosuppression drugs. It may be daily or every other day and the replacement with airborne. The duration and the discontinuation number of procedures for antibody-mediated rejection protocol may use 5 or 6 sessions, daily or every other day, or may be based on the number of treatment on both plasma exchange kidney function improvement and the decreasing DSA or non-HLA antibody levels. So there are many of the plasma exchange challenges, including the technique, the target molecules and its kinetic, the doses and the replacement and the frequencies, and according to the guidelines with specific patient and individualization of therapy